Hello and welcome everyone. My name is Caleb from the task team at the National Rural Health Resource Center. A quick note, our session will go a little beyond our scheduled time, but it shouldn't be too much of a problem as we have a half-an-hour break scheduled after this session as opposed to our 50-minute breaks that we are used to. Afternoon, our session today is the changing landscape of quality reporting, and Carla Wang from Stratis Health will present on identifying trends in the CMS quality measure reporting programs, as well as discussing implications for critical access hospitals and Mbquip. And if you don't know Carla, please do make an effort to get to know Carla. She's wonderful. She's a program specialist or a senior program manager for Stratis Health, leading their rural-focused programs. For more than 20 years, Carla has led a wide variety of projects supporting rural hospitals and providers to improve quality and patient safety, including developing palliative care services, implementing quality management methods, preventing readmissions, and other population health efforts. She currently leads HRSA's Federal Office of Rural Health Policy funded Rural Quality Improvement Technical Assistance Program, or RQITA, which assists rural providers with quality reporting and improvement, and is the technical assistance lead for the Federal Office of Rural Health Policy funded Rural Health Value Program. She has a master's degree in public health administration from University of Minnesota and an undergrad in community health education from Minnesota State University, Moorhead. And she's also a certified professional in healthcare quality. So please join me in welcoming Carla.
Thanks, Caleb. Really happy to be here with everyone this afternoon. It's fun to look through the list. Maybe next year I'll get to see you all in person again. We will see what the world brings us. So we're going to dive in. I have lots of information to share with you guys today. I think you are all mostly familiar with Stratis Health. We are based in Minnesota. As Caleb mentioned, we lead collaboration, innovation, and healthcare quality. We like to say that we work at the intersection of research, policy, and practice. And I like to call that out when I do this type of a session, because really what I'm going to be talking about is the policy side of what's happening with quality reporting, and hopefully linking that to what we think might happen on the practice side. We do have a long history of working with rural providers, critical access hospitals, and the FLEX program. I haven't been around for all 25 years, but I have worked with the FLEX program either in Minnesota or in kind of variety of roles nationally, maybe 21 or 22 years. So most of that time I have been around. I actually had the honor of being interviewed about the history of Mbquip recently. So I have been around since the beginning of that. All right. We do serve as the Rural Quality Improvement Technical Assistance Center. I think you regularly hear from my colleagues, Sarah Brinkman, Janelle Shearer, Robin Carlson, Laura Grangard. I'm really just privileged to work with an amazing team to get to provide support to the FLEX programs and the MBQIP, as well as the Small Healthcare Provider Quality Improvement Grantees, which is another program out of FORHP. So what we're going to do today, we heard this a little bit from Caleb already, but we're going to talk about trends in quality reporting. I'm going to do an overview of what CMS is calling their meaningful measures framework. It's kind of the big picture of what CMS wants to do with measurement. We're going to talk a bit about electronic clinical quality measures, or ECQMs, and then we're going to talk about recent and proposed changes to CMS quality programs, with the intent of linking that all back to the bigger picture of what's happening or what may be happening with Mbquip. So I think this little I call it the sunshine graphic that Laura did from Natalia's slides that show all the different types of measures that they're trying to think about that we might be able to pull into the Mbquip program. We're going to talk about a bunch of those different rays on that sunshine graphic today. All right, I think you all know what Mbquip is, but just as a landscape setting, it's CQI activity under the FLEX program through the Federal Office of Rural Health Policy. Intent is to improve quality of care by increasing quality data reporting and driving improvement based on that data. And it's a common set of rural relevant hospital measures with technical assistance, encouragement, and support. It also, the national nature of the measures allows FORHP to demonstrate the impact of hospital and state-based efforts on a national scale. So I think one of the opportunities and challenges we face with MBQIP is how do we have measures that we can roll up at a national level and show that that impact kind of both at the state, hospital, and national level. So this is the current core MBQIP measures. Most of them go into something called the Hospital Quality Reporting Database, QualityNet. Sometimes it gets referred to as the warehouse. That's where your outpatient measures that are chart abstracted go. That's where if you do, there's a couple measures that you just go in and enter them directly into what's the HARP is the hospital portal. Your HCAHPS data, the hospital HCAHPS data actually also ends up in this same warehouse. So that's one channel, several channels under where with one kind of landing point. There's also the National Healthcare Safety Network that's run by CDC. That's where the healthcare worker immunization measure goes. That's where the antibiotic stewardship data goes. That's where the hospital acquired infection data goes if your hospitals are reporting that. And then there is the Emergency Department Transfer Communication Measure, which goes in individually to each state flex program or to a proxy, depending on how you have that structured in your state. So when I present this slide to hospitals, I always say, I'm sorry. I know that it's complicated. Part of the goal with Mbquip, especially in early years, and I think continuing, is really try to how do we help critical access hospitals be aligned and prepared to participate in these other federal systems and programs. So that's one of the reasons that we try to help with support for the navigation of these different systems is how do we have that alignment. This is where I'm going to go a little bit into the wonky weeds, and that's where we're going to spend most of our time is talking about some of the rulemaking pieces. So those of you, if you've been around for a little while, you probably notice that the quality measures keep changing. They change on a regular basis. There is actually a bit of method to the madness. There's an annual rulemaking cycle. The Inpatient Prospective Payment System Rule, or the IPPS rule, defines the inpatient quality reporting program measures and the Medicare Promoting Interoperability Program. We're going to talk a bit more about that Promoting Interoperability Program because that's where most of the Ecqms, electronic clinical quality measures, sit, and critical access hospitals are held to the Promoting Interoperability Program requirements. The Inpatient Quality Reporting Program is for the PPS hospitals are required, but the measures are available for voluntary reporting for critical access hospitals. So that all comes through the Inpatient Prospective Payment System Rule, the IPPS rule. The Outpatient Prospective Payment System Rule defines the outpatient quality reporting measures. So the Outpatient Quality Reporting Program, again, required for PPS hospitals, the measures are voluntary for critical access hospitals. But if it ever feels like, even though your emergency department or the emergency department is attached to the inpatient of the hospital, the quality programs and the rulemaking process are actually on two separate timelines done by two different separate teams at CMS. So if it sometimes feels like there's disconnect, there is. So CMS has gotten better, I think, over the last couple of years about trying to have better alignment across the different programs, but they are kind of operated under a different set of rulemaking timelines and with different teams at CMS that run those. So even before we get to the rulemaking process, the measures are typically endorsed by the National Quality Forum, which is a national stakeholder body. They have a contract with CMS, with HHS, to look more broadly at kind of what, doing a review of measures as part of the rulemaking process. They also have a process by which measure developers can have a measure be endorsed. That kind of shows that it has high quality relevancy, that what the measure says it's measuring, it actually is measuring. So there's an endorsement process. But then the NQF also runs something called the Measures Application Partnership, or the MAP. So rulemaking usually starts kind of in the spring. So sometime late this winter, CMS will provide what they call a measures under consideration list, or a MUC list. The MUC list will go to the NQF MAP, the National Quality Forum Measures Application Partnership, who has several work groups, including one that's focused on rural, that will provide recommendations based on the measures under consideration that CMS has provided. CMS will then take those recommendations and follow them or not. They are required to have the measures go through the process. They are not required to kind of follow what the recommendations by the process are. And then the measures may or may not go into the rulemaking process. So it really is an annual process that keeps kind of circling and circling. So CMS measures are regularly added. Topped out is one of the things. There's actually an official definition that says there's not really opportunity for improvement for this measure anymore. So we're going to take it out of the measure set. And then they also just plain old retire or remove different measures. So that's kind of the big picture overview of the kind of process of what happens in terms of the federal measures. This is what it looks like in terms of the outcome. So these are the MBQIP measures that have been around since 2014. The ones that are in red and have a line through them have been retired or removed by CMS. So I was telling Kayla before this session started, for a good handful of years in there, when the proposed rules come out, I would kind of open them up and hold my breath and think, okay, what measure are they taking away this year? We're still there, although now CMS has kind of started to shift back in towards thinking about what are some additional measures or what are other areas that we want to focus on, or different kind of channels. So there is starting to be potentially some measures coming back, but certainly the impact of this whole process has been that a lot of the measures, particularly around heart failure and pneumonia, that were pretty relevant for small rural hospitals have been retired or removed by CMS. Okay, so I'm going to take a breath. Please feel free to either ask questions or drop them in the chat if you have them while we go. I'm happy to try to address them while we go or take them at the end. I only have one slide on this next section, but it's an important one. Really wanted to give you this picture of what CMS is using as sort of their guidance when they're thinking about what the measure changes are. They're thinking about how they're using measures in their program. So they are using this framework called Meaningful Measures 2.0. There was a 1.0. This is the second iteration of it. They use sort of this house graphic to talk about the different key areas that they want to be sure that they're measuring in. So person-centered care, safety, chronic conditions, seamless care coordination, behavioral health, wellness and prevention, affordability and efficiency are all measured topics. They also have equity here, although they also have equity at the bottom. So they have it in both places, definitely highlighting the current administration really pushing hard, as I think is important, around kind of how do we address and get at equity in terms of healthcare, because really I think if you think about it, it's pretty hard to have quality if you also don't have equity. Those two things are really linked. So you look at, these are the different types of measure categories that we tend to see coming out from CMS. They're also really pushing hard on this patient and caregiver voice. So really wanting to have quality and input be defined by the patients and the caregivers. So that HCAHPS is probably the primary MBQIP measure that aligns with that right now, but definitely some movement towards what's called patient-reported outcome measures. So for example, there's a proposed measure right now for folks that around hip and knee replacement, that you actually ask the patient, do you have better function at 90 days? That's a patient-reported outcome. So that's a proposed measure that's out there right now if folks are doing hip and knee replacements. So a couple of key points that I want to call out for you on this, because it really, I think, is the roadmap to what we're seeing in some of the measure changes, is first that CMS wants to move to what they're calling fully digital measures by 2025. So really pushing hard on the digital side of this. I think it's interesting that they're starting to use the word digital instead of electronic. What that means, I think they're trying to look at sort of a broader look of what they mean by trying to get that information out. They are continuing to focus on something called the Fast Healthcare Interoperability Resources, or FHIR standards. I am not a techie, but they talk about that a lot. There's actually even some pieces in the proposed rule about it. But really with the vision that if folks are all using this FHIR standard, or the electronic health records are using this FHIR standard, then it'll be much simpler to be able to pull that quality data back out, rather than the current process of either chart abstracted or having the way that Ecqms are currently structured, which comes through a different sort of programming structure. Again, I'm the policy person, not the IT, but certainly a big push towards accelerating that transition to fully digital measures. So I think we're going to continue to see movement that way. They're also talking about trying to incorporate all payer data. That would be fantastic. I will offer some skepticism that it'll happen by 2025. So currently what happens right now with several of the measures that get calculated by CMS using claims data, they're only using Medicare fee-for-service data. They're not using Medicare Advantage, they're not using Medicaid, they're not using commercial. It's only Medicare fee-for-service. If we could get to that all-payer data, I think it would be much more meaningful, particularly small hospitals. It would increase kind of the population that you're getting captured. I've been working in quality measurement for a long time. They've been talking about trying to incorporate all-payer data for a long time. I hope that it happens. I have a little skepticism it'll happen by 2025. But hopefully we're moving that direction. We also see prioritization towards outcome and patient-reported measures. So outcomes, the ultimate outcome, they really have done a lot of work around mortality measures, but also looking at readmissions, different patient safety events. So really a push towards those outcomes, which I think is meaningful, but is also really hard to measure in a reliable way when you have small volumes or low volumes like critical access hospitals. We already mentioned patient-reported measures, and then the last bullet I think is we're really seeing in this year's rulemaking is how do they develop and implement measures that help reflect or address social and economic determinants. So trying to get more at some of those equity pieces, and we're seeing that play out with some of the new measures that we anticipate will be coming down the pike that are proposed. So that is, if you want to think about what CMS's strategic plan is for measurement, this is the best snapshot. There is a link if you want all the additional details. All these slides will be posted. I have hyperlinks all the way through them because I know there's a lot of information here. And if people want to dig into the original source, I tried to link that everywhere. Okay, so we're going to talk next about Ecqms, electronic clinical quality measures. It really is just that it's data electronically extracted from electronic health record or health technology systems to measure quality of care. So it's really just a quality measure that gets pulled out electronically. So Ecqms, this is CMS's vision. When they first started incorporating Ecqms into the inpatient quality reporting program, they said in their proposed rulemaking that hospitals will be able to switch primarily to EHR-based data reporting for many of the measures currently manually chart abstracted and submitted for the IQR program. I like to highlight for you all that this was in 2016. So when CMS originally rolled this out, they said, we're going to have everybody report, 4 measures for 1 quarter in 2017. And then after that, everybody's going to be able to report everything electronically. Well, 2016 was a few years ago. We're still not there, but I think we're definitely getting closer. They've made pretty significant progress in pushing this forward in the last couple of years. And I'm not going to remember who said it. I know it's a quote that Terry Hill often uses, but it's something like we overestimate the amount of change in the next 2 years, but underestimate the amount of change that will happen in 10. So I do think that this kind of purely electronic or that push towards digital will happen. I just don't know if it'll happen as soon as they think it will, as certainly the Ecqms took longer than they had anticipated. The Ecqm reporting requirements I want to highlight for you guys because it is required for critical access hospitals as part of the Medicare Promoting Interoperability Program. So the Medicare Promoting Interoperability Program was formerly known as the EHR Incentive Program, more oftentimes called in the field meaningful use. So if you ever hear people talking about meaningful use or the EHR Incentive Program, formal name from it now at this point in time is the Medicare Promoting Interoperability Program. So Ecqms do need to be submitted as part of that program once per year. So in calendar year 2022, the submission deadline will be at the end of February of 2023. And they've been progressively adding the increase of reporting for Ecqms by quarters. So I know that 2020 and 2021 reporting are past, but I wanted you to see the progression. So for several years, the reporting requirement was 1 self-selected quarter for self-selected Ecqms. And you can see here that's slowly increasing. So there'll be 2 quarters, 3 quarters, 4 quarters. So starting 2023, they are going to be looking for 4 quarters of data submission. They've also started to add in required measures, and I'll show you the measures in just a moment. So there's a set of measures, hospitals get to pick 3 of them, and in 2022, they pick 3, plus they have to do the safe use of opioids measure, which is around concurrent prescribing between multiple opioids or benzodiazepine. So those will be the required measures for 2022. These measure requirements also align. So for critical access hospitals, they have to do it from Medicare Promoting Interoperability Program. If I'm a PPS hospital, if I submit these measures, it meets the requirements for the IQR and the Promoting Interoperability program. So they have gotten those to align. A few years ago, there was different requirements between the two different programs. So they have gotten that to line up. Here is the list of measures. The color coding is mine. These are the measures that are available for 2022. So I would say that the measures in blue are relevant for most critical access hospitals. So it's the median admit to decision time for people who are admitted from the emergency department, the VTE or venous thromboembolism prophylaxis, and then that safe use of opioids. I actually think it's relevant and it is also required. The PCO5, if you're delivering babies, that would be a measure that I encourage people to report. The other measures are around intensive care and stroke. So a lot of those, most critical access hospitals don't have intensive care units, nor do they keep their inpatient stroke measures. So even though these measures, there is required reporting, we continue to have some challenges around the rural relevancy of the availability of measures. What does it mean to report? Essentially, it's that you report patient level data using a quality reporting data architecture. That's just kind of the name of the file format. Meeting the population. You can also submit a zero denominator declaration. So you can go in and say, I don't have any cases, or you can go in and say, I have less than 5 cases in the reporting quarter. Why they don't have those be the same thing, I don't know, but they are 2 separate things. You either say I have 0 cases, or I have a case threshold exemption of less than 5. So that's the reporting process. These do actually go in through that same hospital quality reporting system. Let's see, my slides don't want to move. Here we go. There is a hardship exemption option. Critical access hospitals can submit this. It is on a case by case. There's not a blanket exemption. So it's not a given that you're going to get a hardship exemption, but there is an option. There's a link for more information if you have hospitals that are facing this. And then what I really want to highlight for you guys, this is the biggest change, and I think it's an important one in terms of critical access hospitals and ECQMs, is that until now, ECQM reporting has essentially been an IT exercise. Can you get your data out of your system in the format that it needs to be in to go into the other system? The data doesn't go anywhere. It's kind of a black box. However, starting with the calendar year 2021 data that was submitted this spring, CMS is going to start publicly reporting the ECQM results. So now this quality data is starting to be treated like the other quality measures that we're more used to. It'll be out on the Care Compare site. So hospitals will be able to review that data before it's made public. I anticipate it'll probably be an October release is typically about the timeline for that. So the data will be on CMS Care Compare. It'll also be on the provider data catalog, which is where they post all the public use files. And then just to highlight that for IQR eligible hospitals, there's a validation process. Critical access hospitals don't participate in that because they're only doing the validation for the IQR piece of that work. So big news that this is shifting. There also, as we get to talking about some of the newer measures, there's a handful of new ECQMs that will be coming into play as well. Okay, so now I'm really going to go into, we're going to do a couple different things. We're going to talk about what's coming in the near term. So it's been proposed, it's been finalized, it's kind of in process. And then we're going to talk about what's proposed. So we have kind of 2 pieces that'll come up. I'll try to keep it clean between those. So one of the things that came through rulemaking a couple of years ago and is now just starting to get into the implementation phase is something called the hybrid hospital-wide all-cause readmission measure. So right now there's all-cause readmissions measures that are calculated using claims only, and then they do some risk standardization based off the data that comes in claims. What they're moving to is submission of clinical variables that they will link with claims to have a risk standardized readmissions rate. So this was piloted back in 2018, and now they're shifting to full implementation. There's a voluntary reporting program. This is part of the inpatient quality reporting, so required for the one that's required for PPS hospitals. It is voluntary for even for PPS hospitals for the next 2 years, but then once we get into 2023, 24-ish, it'll be required for that inpatient for the PPS hospitals. So they'll submit this data of patient level data. CMS will match that up with the claims, and they'll use that to do a risk standardized all cause readmissions rate. Once they shift to having that be required under the inpatient quality reporting program, they are no longer going to calculate or report the claims-based only hospital-wide readmissions program. So this is me waving my hand saying, hey, this measure gets used in lots of different programs for lots of different things. It's one of the more common measures used in different value-based care programs. If critical access hospitals aren't submitting the clinical data, they won't have this calculated anymore. So for some hospitals, they might be relieved by that. It's one less thing they don't have to worry about. But I do think it's sort of important to be paying attention that this is definitely a direction that we're seeing CMS go. And if we want critical access hospitals to have data and measures that kind of show some equivalency depending on the services that they're providing, this is an important one to be paying attention to. Just a snapshot, here's what the clinical variables are to give you an idea of what that would look like to come out of the system. And then I do have some links here for all the reporting information if you have hospitals that are interested in that. Okay, so that's a big one, that shift to hybrid measures. So what I want to share with you guys next is that last year's rulemaking process. So the rulemaking process that happens in 2021 goes into effect in 2022. So the proposed measures that we're looking at right now the proposed rules are all for 2023. So this is what came out of last year's rulemaking process. And these are the new measures that are in place or in process of being implemented. So the first one is the maternal mortality structural measure. And I did have to giggle a little bit when Laura called me out in the first session today and said, as Carla would say, if you're delivering babies, you should be doing this measure. And I do think that is true. This is basically just reporting on whether or not you're participating in a perinatal quality improvement program if you provide inpatient labor delivering care. There's some challenges with that. We have learned over the course of the last 6 or 8 months or so that not all states have an active perinatal quality improvement program that critical access hospitals or their hospitals can participate in. For some of them, if there is a program, there's a fairly significant expenses to submit data. So we have some opportunities in terms of making sure that there is programs that are relevant for critical access hospitals to participate in, but really trying to dig into and make sure that we're providing the best quality of care possible in terms of labor and delivery and taking care of new moms and babies. The other new measures that came out of last year, there's a COVID-19 vaccination coverage among healthcare professionals measure. Looks pretty similar in terms of how it's reported into CDC and HSN as the healthcare worker immunization measure. So this is available for reporting. It's not required at this point for critical access hospitals. My response is always, if you're already collecting the data, I encourage you to report it, but that's another measure that has come through. They're also looking at, I talked in a little bit in depth about the hybrid readmissions measure. They're also going to be doing a hybrid all-cause risk standardized mortality measure. So similar data set, little slightly different timeline for that. So moving both readmissions and mortality to that hybrid structure. And then there will be 2 new Ecqms that will be available for 2023 reporting. So the Ecqms go in calendar years. Both are related to harm, severe hypoglycemia and severe hyperglycemia. So those will both be available starting in 2023. More new measures. So this is out of the last year's outpatient rule. So they are removing 2 of the chart abstracted measures in calendar year 2023. So this is OP2 and OP3. So these are currently Mbquip measures. The last quarter of available submission at this point is Q1 2023. So we encourage your hospitals to be continuing to report this throughout 2022 and into the first quarter of 2023. What they're doing is actually adding a new Ecqm called ST segment elevation myocardial infarction. So a STEMI Ecqm, which is clinically similar to OP2 and OP3. It is the first Ecqm under the outpatient quality reporting program. At this point, it does not align with the promoting interoperability requirements for Ecqm submission. I haven't seen a lot of information about the reporting channel. I assume it will be similar to the other Ecqms, but I think an important step that they are shifting to have an Ecqm under the outpatient program as well. And then there is the same COVID-19 vaccination coverage among healthcare professionals is also in the outpatient side. So CMS essentially put that measure into every type of reporting program: hospital, inpatient, outpatient, home care, hospice, you name it. They added that COVID vaccination healthcare professional measure in last year.
Carla?
Yeah.
Hi, it's Catherine.
Hey, Catherine.
Maybe I'm getting ahead, but any word on for OP 2 and 3 if that ECQM you mentioned is going to replace those in MBQIP?
Great question. We'll get there.
Oh, I read your mind.
Couple other new measures. There's a breast cancer screening recall rate. So if your hospitals do outpatient mammography screening, they don't have to do anything. This gets calculated for them. There is a claims-based measure that will take and look at a target recall range. So if you're doing mammograms, you should certainly have some people coming back, but they don't want too many people coming back, because if you're bringing lots and lots of people back, you might be exposing them to unnecessary radiation. So there's a target range that they're looking for. This is already being calculated right now. So this is one that will just show up for them if they should be watching on their reporting fields. So, or they get preview reports that come out, sorry. For the OQR eligible hospitals, so these are two measures that are currently available voluntarily for the OPPS hospitals. So there's a outpatient ambulatory surgery center CAPS that's voluntary. They're shifting that to mandatory starting in calendar year 2024. And then this other one is also one of those patient-reported outcome measures. It's the improvement in patient visual function within 90 days following cataract surgery. So hospitals or outpatient surgery centers can report that voluntarily now. In last year's rulemaking, they said that they were going to make it voluntary or mandatory starting in 2025. In this year's rulemaking, they're questioning potentially rolling that back. So we'll see. If your hospitals are doing cataract surgeries, I'd encourage them to be thinking about this measure. It really does give you that patient-reported perspective on whether or not they have improved visual function. But at this point, looks still voluntary for everybody, may or may not become mandatory for the OPPS facilities. It's a lot of letters to try to keep straight. So everything I've talked about before now is coming. It's happening, final rules. What we're going to talk about next is actually proposed. These are all proposed rule. So the IPPS proposed rule came out in April. The comment period closed in June. There were 10 new measures in this. Not all of them are relevant for critical access hospitals, but lots of new measures. So the first two I think are particularly relevant. I will be somewhat surprised if CMS does not move forward with them in some shape or fashion. The first is a hospital commitment to health equity, where it's a structural. So it's again sort of an attestation piece, and you report in to say that you're looking at equity as a strategic priority, you're collecting data, you're analyzing data, you're doing quality improvement, you're engaging leadership. So what are the different kind of aspects of a health equity program, and are you implementing them? So that'll be a structural measure. Anticipate that will be available for reporting in 2023. The next one is around health-related social needs, social determinants of health, social drivers of health. There's lots of different words for this. CMS likes to have their own acronyms, so they're calling it HRSN, health-related social needs. So they're looking at whether or not inpatients have been screened for health-related social needs. In particular, they're looking at food insecurity, housing instability, transportation, utility, and interpersonal safety. So those are the different areas they're looking for folks to be screening. And then they're also looking for whether or not, did you do the screening, and then how many of your patients reported positive for any of those 5 areas. So it will be interesting to see how I anticipate the screening measure will go through. There's been some pushback, Stratis Health included in our comments. I think it's important to track how many people actually had positive screens, but I don't think that's a reflection of hospital quality. I think it's a reflection of the community that they serve So whether or not that's something that should be reported on Care Compare is sort of what we push back on. There's also some concern, I think, here is that, okay, if you're screening for it, what do you do about it? So I think there's some scrambling and some work that needs to be done in terms of thinking about how do you both assess, accurately assess, appropriately assess this, and how do you get people the resources that they need? So a lot of work I anticipate to be coming in this space in the next year or two. The rest of these are probably a little bit more dependent on your service level. So again, there's the patient reported outcome measure that I mentioned as an example at the beginning. If you're doing elective total hips or total knees, they're looking at a pre-post survey for patient outcomes. They're doing some revisions to the claims-based hospital risk standardized complication rate for total hips and total knees. They're looking at some revisions around the NHSN HAI measures using EHR-derived data for CDI, so C. diff, and hospital onset bacteremia and fungemia. Ooh, those are hard words to me. That's inclusive of the CLABSI and MRSA measures, so looking at sort of some revisions to those. Not part of this, but I do want to mention it because I know there's a lot of interest in having the HAI data be useful. Not part of this revised set, but FRHP, Stratis Health, and has had an opportunity with FRH to have several conversations with CDC to start talking about and thinking about how we make that HAI data more useful. So right now, all the measures are a standardized infection ratio or a SIR. If you are not expected to have any infections, you don't get an infection ratio calculated. So for most critical access hospitals, they almost never have like the actual quality measure reported out of that HAI data, even if they're reporting it. So this is a different change around how they're actually capturing and looking at that data, but they are also having conversations about how to make the HAI measures more useful in low volume facilities. So that'll be one of those changes that I think will come, but it won't come immediately. And we're excited to hear that CDC is actually thinking about it, talking about it, trying to see what they can do to make that meaningful. The last measure here that I want to measure, there's a Medicare spend per beneficiary calculation that CMS does. It's part of the value-based purchasing program for PPS hospitals. Doesn't necessarily apply to critical access hospitals, but it is something that they're proposing a revision to. So have it on the list. Phew, okay, there's more. There's new ECQMs that are being required. Now this does apply to critical access hospitals. This is part of the Promoting Interoperability program. So they're looking to increase the requirements. Right now it's 4 measures. They're looking to increase it to 6 measures, where hospitals would pick 3 measures from a list and then have 3 required measures starting in calendar year 2024. The measures that they're adding to the list are hospital harm related to opioid-related adverse events, essentially looking at whether or not you had to do naloxone or some other sort of opioid rescue while they're in the inpatient setting. There's a global malnutrition composite score, which I think will be pretty interesting and likely pretty relevant for most of our hospitals, where they're actually doing an assessment of malnutrition risk on their inpatients. And if there is a malnutrition risk identified, how they kind of support next steps with that. So really sort of aligns with those social drivers or health-related social needs. And then the last 2 that they're looking at making required are the severe OB complications and cesarean births. So again, if you don't deliver babies, those measures are not relevant to you. But if you do, they're looking at making those required measures starting in 2024. Oh, I went the wrong way, you guys. I'm sorry. More changes. This is all to the Promoting Interoperability program. Just wanted you guys to be aware of this. These aren't specifically measures, but I think what may have an impact in some of the quality related work that critical access hospitals are doing. Right now, as part of the Promoting Interoperability program, there's some bonus points to that calculation of whether or not they do a query of the prescription drug monitoring program, the PDMP, how often that happens for patients. So that's a kind of optional bonus measure of what happens right now with the Promoting Interoperability program. They're looking at requiring that starting, I believe, in 2024. They're also looking at requiring the antimicrobial use and resistance surveillance, which goes through the NHSN through CDC as a required measure to one of the other objectives under the Promoting Interoperability program. I kind of think this one might not go through. We questioned with CDC and have raised up to CMS. In the rulemaking, they actually said that over 1,000 critical access hospitals already submit that data. And we were like, I don't think that's right. It's actually only about 200. So we'll see what happens there if they do actually make this required or if it's going to be optional. They're also doing some changes in scoring methodology in this space to kind of emphasize how important that clinical data exchange is in terms of having interoperable health records. And then they are looking at starting to publicly report the Promoting Interoperability program data. Right now, again, that's a little bit of a black box. Critical access hospitals will take a payment hit if they don't meet the program requirements, but there's no information available about how many hospitals meet the requirements, what their total scores are, that type of thing. So they're looking at doing some public reporting of that starting in 2023. Phew, still more, you guys. There was a lot this year. So this is my crystal ball. I like to look at when CMS puts requests for information into their rulemaking. I always feel like it's a little bit of a lens or a crystal ball into what CMS is thinking about for future rulemaking. They had several in the IPPS proposed rule. These are the ones that were related to quality. There was one around input on what they should do related to climate change. So both around emergency preparedness planning and potentially around sort of environmental impact of hospitals. So what is your kind of footprint, your environmental footprint as a hospital? They were looking for feedback on overarching principles for measuring healthcare quality disparities. So right now, CMS is doing some confidential data reports out to hospitals that will do some stratification by dual eligibility on some of the measures. That's really the only data they're doing any sort of disparity split on right now. So really looking for input broadly on a variety of principles around how they might use that data to better highlight or identify disparities and focus on improvement for them. More use I mentioned earlier about this FHIR, the Fast Healthcare Interoperability Resources. So really kind of digging in on some of the standards. The next one, the Advancing Trusted Framework and Common Agreement, the TEFCA, is also an interoperability. Those are both of those are really around kind of standards. When I see that information, it makes sense to me from a very high level conceptual standpoint. I would ask those of you in the field who are closer to it than I am to understand whether or not they're actually realistic. If the systems that critical access hospitals in place can actually meet those standards, I don't have a good sense of what that looks like from the ground, but from a conceptual standpoint, they make sense. And then they're also looking at development of a birthing friendly hospital designation using some of the measures that we talked about earlier. Okay, guys, I'm almost there. So the OPPS, that was all from the inpatient perspective rule. Literally, there was like more than 300 pages that were just on quality this year. The OPPS rule, there actually were no measure additions or removals this year for the outpatient quality reporting program. But they have a whole request for information around reporting for the rural emergency hospital quality reporting. So as I think you guys are aware, there's a new provider type designation that will be available starting in 2023. In the legislation, it requires that the rural emergency hospital programs are reporting quality data. So when I look at this lens, I think, okay, that's important for those hospitals that can convert to that status. But it also means that these measures would be available likely for voluntary reporting more broadly. So if we're trying to look at what's available at a national level for Mbquip reporting, these measures might be available. So they are specifically looking for input on some of the OQR measures, both OP22 and OP3, that's the chart abstracted that's slated to be removed, or the STEMI Ecqm replacement. So they want input on whether or not those measures should be included. They're looking at OP18 and OP22, which are current outpatient measures. They're also talking about whether or not they should pull back or look at recently retired OQR measures. So whether or not they would bring back the OP4 aspirin at arrival measure or the OP20, which was door to diagnostic evaluation. They're also asking for input on MBQIP measures, including the Emergency Department Transfer Communication measure, and then a couple of claims-based measures. So there's a claims-based measure where they're looking at use of contrast material in abdomen CTs, and a claims-based measure looking at whether or not people end up in the hospital after outpatient colonoscopy. So those are all the measures that they're talking about potential for the rural emergency hospital. They also had a broader RFAI looking for input on a variety of measure topics like telehealth, maternal health, mental health and behavioral health, equity, and then also kind of emergency department service utilization. So are you seeing a lot of repeat users, for example? I would tell you, disappointed out of this for a couple of reasons. One is that I was a little bit surprised and disappointed not to see any sort of patient experience measures. So I've been hoping that this might be an avenue to have a nationally standardized ED CAPS. So there is a survey, but there's no reporting mechanism. That was not mentioned, nor was any sort of patient safety type of measures mentioned at this point in the proposed rule. Phew. So back to Catherine's question, what does this mean for MBQIP? That's a really, really good question. There's a lot happening in the measure space. So I do anticipate some focus on ongoing measures that align with other federal programs and priorities. So certainly FRHB is trying to look at what's happening out there. How do we take advantage of what exists, what's relevant? We have to have continued advocacy for increased availability of rural relevant measures. And then I think where it gets a little stickier and where I think there's a lot of the discussion happening right now is how do we are we able to incorporate some of these other measures? So are we able to incorporate the Ecqm data if benchmarking data back out to critical access hospitals is been sort of a key component of MBQIP? Are we able to get that data in a format that we can do to have that sharing as part of the program? Do we do that with Ecqms, with the readmissions or other claims-based, potentially the hybrid measures, potentially the disparities or social needs related measures, all while kind of recognizing that there's continued interest in other important areas of interest. So that emergency department patient experience, swing bed care, all the types of things that many of you are focusing on as part of your Flex QI project. So while we continue to sort of wade through what's available at a national level, what data might be available, what data is useful, we also anticipate continued intention and focus on improvement. So all along, I think really the intent has been the reason to report is so you have data that you're looking at and improving. So how do we keep that focus there as well? My ongoing plea, which is really important that input happens to comments and rules and recommendations. So right now the OPPS rule is open for comment. Whether or not you guys do that as part of your office, whether or not your hospital association, certainly the National Rural Health Association will be providing comment. Anytime you can provide feedback, particularly if you're having feedback directly from your hospitals up through those rules and regulations processes, it's really important. And then the National Quality Reform MAP Rural Health Advisory Group is also a really important kind of resource that looks at recommendations and guidance that CMS turns to look for. So link to that as well. They just had a new recent report coming out saying sort of, here's a set of NQF endorsed measures that we think are important. The reporting channel piece is a really challenging piece of this. So there's, first there's availability of measures that make sense in rural settings, low volume hospitals, and whether or not they're adequately specified, that type of thing. And then the next step is whether or not there's actually a channel for reporting if there's something that we want to capture more broadly, particularly at a national level. So those are kind of the two key pieces there. So I'm going to stop, see what questions, comments folks have. That's a lot of information. The rest of my slides are just links to information for more stuff.
Awesome. Thank you, Carla. And just to let everyone know, we'll end at the bottom of the hour, 1:30, and then we will have a 15-minute break before our next session focused on new tools and support for leadership development. But let's, since we have Carla captive, let's ask her some questions about reporting. A quick note, Lisa, I see you're off of mute and I can see your smiling face, so I'll give you a
Hey, Lisa.
Hello, my good friend Carla. So I'm going to just offer up a comment here that I think will be controversial, and don't shoot the messenger. But I had seen something just this past couple of days, I think, about Mbquip and how the Mbquip measures and the whole Mbquip system, when it was initially set up, was completely and absolutely relevant and the perfect solution to what we needed for quality. But we are now in 2022, and have those measures changed? Should Mbquip change? Should there be a new system in place? So I know that we have 1 minute to answer that. So you don't need to respond. I just wanted to sort of get it out there into the universe, and then all my good friends across the country can hate me.
Yeah. I guess my short answer would be yes, the environment has changed.
So, all right, Caleb, thank you.
Thank you, Lisa. I do want to make sure to promote RQITA, the assistance that they provide there at Stratis Health. Anybody who saw the entire presentation knows and appreciates the depth that is involved in these quality reporting measures. Carla and her team at Stratis Health and RQITA are very helpful and can not only provide you with the understanding and support that you need, but they can also help your hospitals get to a place where they can track and report their data. So if you do need any help, please don't hesitate to reach out. And as always, there's no wrong door. Go ahead, Carla.
And a reminder, this was like big picture. This isn't like, here's the measures for your hospital report. This is what's happening in the landscape, was the intent of this presentation, if anybody is feeling like their anxiety has gone up. It's not my intent. My intent is to give you a picture of what's happening.
I have a quiz that I'm going to send all of you afterwards to see if you
All right, guys. Well, we are now on break until 1:45 Central Time, when our next session, then some focus on new tools to support rural health leadership with Terry Hill and Shannon Sutton. So we'll see you back there. Thanks, Carla.
All right. Yeah. Thanks everyone for joining us.